Hello dear students, the topic of discussion in this video is going to be the syphilis. So this was once asked as a theory question in medicine paper. So let us begin the discussion. What is syphilis? So it can also be mentioned as lues, that is the other name for syphilis. It is a chronic systemic infection which is produced by the Treponema pallidum, which is a spirochete. And what is the source of infection? So contact with the open infectious lesions of the primary or secondary syphilis could be the source of infection. And what are the areas which are going to be affected? Usually the genitalia and other mucosa and also fingers and nipples, depending upon the various sexual practices of the human beings. And what are the infectious lesions? Chancre, remember this term is very important. Chancre literally means ulcer, but in the case of syphilis we call it as hard chancre. Very important term to remember and also write in the examination. Mucous patches, skin rash. So we will see what are all this and which type of syphilis we are going to see them. Right. Coming to the modes of transmission, sexual contact is the commonest and most important one to remember. We have to ask the history whenever we have a doubt for the patient. About regarding the sexual history, recent sexual history. Transplacental from mother to fetus, and this is congenital syphilis. Blood transfusion, unfortunate patients may also acquire syphilis treponema pallidum through the blood. Direct contact, though rare, it can be seen in medical personnel who handle the syphilis patients. Remember this treponema pallidum, it can cross and it can infect the individuals if it comes in contact with the mucous membrane, even if it is intact, and it can also enter through the abraded skin but not intact skin. It's very difficult, and ultimately through the lymphatics it will reach the bloodstream and thereby produce systemic infection. So broadly, syphilis is classified as acquired syphilis and congenital syphilis. Congenital syphilis, you can remember, it will produce either intrauterine death or it can produce early and late congenital syphilis. Right. And in the acquired, you can remember there can be primary syphilis, secondary syphilis, latent syphilis, late syphilis. It's also called as tertiary syphilis, where the patients are going to have the skin lesions which are called as gummatous lesions, or the patients can also have the involvement of the cardiovascular system and also neurosyphilis. Right. So now coming to the stage wise, what are the important? This table is important. So stage wise clinical manifestations. So primary stage, primary syphilis, patients are going to have the ulcer over the genitalia, which is called as primary chancre. Remember this primary chancre can also be present in other areas wherever there is entry of this treponema pallidum, not only genitalia, it can also be over the lips and in the oral mucosa, depending upon, like I have told you, various sexual practices, different kinds of sexual practices. And there is going to be lymphadenopathy. Right. And secondary syphilis, where there is going to be if the patient is not treated properly or completely not treated primary syphilis, what will happen is the treponema pallidum, it will reach the bloodstream and thereby it will produce the secondary syphilis where there will be mucocutaneous lesions. And now the lymphadenopathy is not confined to the inguinal group, but it will become generalized lymphadenopathy. Right. Tertiary syphilis, cardiovascular and neurosyphilis. And latent syphilis, remember this latent term is very important, where the peculiarity is the patients do not have any kind of lesions over the skin, no symptoms, no signs, but if you do a serology VDRL, there is going to be positive VDRL test. So this is a characteristic of latent syphilis. First let us discuss the primary syphilis. So like I have told you, remember this is also called as chancre, primary chancre, it's also called as hard chancre. So why is it called hard chancre? So the patients are going to have the ulcer mainly over the genitalia, and the lesions are going to be absolutely painless, and they are going to be very much indurated, just like a button of the shirt. So they are going to be very much indurated hard. That's the reason why they are also called as hard chancre. Right. So now there is going to be regional lymphadenopathy. What are the regional lymph nodes? They are the inguinal group of lymph nodes which you need to remember, and they are going to be same just like the ulcer, painless, non-tender, and there will not be any pus in the lymph node. Right. So what will happen to the primary syphilis? Usually it will heal over a period of 1 to 1.5 months even without any treatment. But if you don't treat the patient, what will happen? This Treponema pallidum, it will raise the bloodstream and thereby it can produce the other types of syphilis, right? Alright, secondary syphilis. Coming to secondary syphilis, it will develop 4 to 10 weeks after the primary syphilis in approximately 3/4 of the patients. And due to the systemic spread, now the patients are going to not only have the skin lesions and mucous lesions, they are going to have generalized malaise, they are going to have fever, there is going to be sore throat, headache, arthralgia, myalgia, all sorts of prodromal symptoms will be there. And coming to the mucosal and skin lesions, they are going to have a skin rash. Approximately 3/4 of the patients of the secondary syphilis will have the skin rash, right? What are the skin lesions which are going to have? Mainly erythematous to brown colored macular lesions will be seen, and again this is going to be generalized, present all over the body, and again there will not be any itching or any kind of a pain because of the skin lesions in the patients, right? Usually the sites are going to be mainly the trunk. And remember, whenever you suspect a patient to have the secondary syphilis, always examine the palms and the soles where the patients can have these kind of hyperpigmented or erythematous macular lesions. Okay, these are also called as syphilids, right? So we have discussed about the hard chancre present over the genitalia. This is going to be the picture of the patient when they present to us, where there is going to be a single ulcer which is going to be non-tender, painless. If you try to palpate, it is going to be very indurated or hard. Now coming to the other lesions in the secondary syphilis, patients can have condylomata lata, which are going to be broad moist plaques which are present over the genitalia, This term is important, condylomata lata, right? Next, mucosa can also have the lesions in the secondary syphilis, where these lesions are going to have peculiar shapes resembling the snail track trails. So these are called as snail track ulcers. So you can see this is a snail track ulcer which is present over the tongue. And remember, the generalized lymphadenopathy is very important, which is going to be found in these patients, right? And most important group is epitrochlear group of lymph nodes, which you have to examine. And less common other systemic findings could be meningitis. So these are very rare, you need not remember, just okay. Next, coming to the latent syphilis. So this is something interesting. After the secondary lesions resolve, okay, some untreated patients can enter into the latent syphilis. Latent syphilis, usually secondary syphilis, we have to treat, mostly we will treat it because it is going to have be very much symptomatic for the patients. But if any of the individuals miss out in this phase, then they are going to land up into the next phase, that is a latent syphilis. So here patients will not have any clinical disease, no clinical lesions will be there, but if you do the serology, they are going to have positive serology for syphilis. And also we can see CSF abnormalities in the neurosyphilis patients. So again, this is divided into early latent if it is within 1 year after the exposure, and it is called as late latent if it is after 1 year. So what is the main difference is, in the early latent syphilis it is sexually transmissible, whereas in the late latent it is not sexually transmitted. But the problem is, if the mother, if she is not getting the proper treatment and if she is having this late latent, then she can infect the fetus. That is a problem. So that's why in gynecology we are going to do the VDRL in all the pregnant women to even identify the late latent syphilis. So yes, so late tertiary syphilis, we also call it as tertiary syphilis, and this may persist many years or even till the death. And there will not be any signs or symptoms, like I have already told you. And what are the manifestations in this? There is going to be skin lesion which are called as gummatous syphilis, where remember, this is called as benign tertiary syphilis. The reason is because it has good response to therapy, gummatous syphilis especially. Gumma are basically granulomatous lesions which can also ulcerate, which are present over the body, right? So this is okay. Cardiovascular neurosyphilis, just remember, cardiovascular, the involvement is going to be mainly of the aorta, and this is called as syphilitic aortitis. In neurosyphilis, patients can have the involvement in the form of asymptomatic meningitis or meningitis which is symptomatic. So these are the ones which you can just broadly remember. Congenital syphilis, we can see this in another video. This is not much required, but I hope in pediatrics this might have been covered, especially the Hutchinson's triad. You might remember Hutchinson's teeth, interstitial keratitis, and the cranial nerve deafness, sensory neural deafness, right? So coming to laboratory diagnosis, this is microbiology. So I hope you remember that in the primary syphilitic phase, with the help of dark field microscopy, dark ground microscope, we can identify the Treponema pallidum because of its corkscrew motility. Okay, and coming to the serological test, we can also have this non-treponemal or non-specific test and treponemal or specific test. I hope you remember VDRL, RPR are the non-specific, non-treponemal tests, whereas this TPHA, FTABS, these are the treponemal or specific tests. So examination of CSF is important if you suspect a patient have neurosyphilis. The other test, chest X-ray ECG, to identify whether if the patient is having severe syphilis. So otherwise we need not do that. So coming to the management, remember the important medication name which you have to remember is benzathine penicillin. Benzathine penicillin in the dosage of 2.4 million units is going to be given 1.2 into right and 1.2 into the left buttock as IM injection only once. Okay, if the patient is allergic to penicillin, then we think of alternatives like doxycycline, erythromycin. Otherwise, benzathine penicillin is the best treatment which we can give. Right. In the secondary syphilis also we are going to use the same thing. Otherwise, procaine penicillin can also be used. In the early latent also we can use benzathine penicillin, but remember in the latent syphilis or tertiary cardiovascular syphilis, we have to treat the patient very aggressively. That's why we are going to give 3 doses of the benzathine penicillin. Right. And in the case of neurosyphilis, remember the benzathine penicillin cannot cross the blood-brain barrier. That's why we are going to use the aqueous crystalline penicillin in these patients. Okay. And also you need to remember about this concept of anaphylaxis to the penicillin. So beware, that's why we are going to give the test dose of the penicillin before giving the complete dose of the penicillin, even if it is second or third time which you are giving the penicillin. Every time you have to give the test dose of injection penicillin. There is one reaction which is called as Jarisch-Herxheimer reaction. So when we give penicillin, what will happen? There is going to be destruction of the Treponema pallidum. Because of this destruction, there is going to be release of cytokines, and because of this cytokines, there is going to be aggravation of the already existing lesions, syphilitic lesions over the patient's body. Along with that, there can be prodromal symptoms, fever, myalgia, arthralgia. So that's why we have to always admit the patient of syphilis. And also most importantly, we have to counsel the patient regarding this Jarisch-Herxheimer reaction which they can develop after giving the penicillin injection, and we have to tell the patient and make them understand that this is absolutely normal and this is actually in one way finding which will say and which will tell us it's a sign that actually the Treponema pallidum is getting destroyed, right? And remember to distinguish between the penicillin allergy, that is anaphylaxis, and Jarisch-Herxheimer reaction. And anaphylaxis, if a patient develops anaphylaxis, treat them immediately. It is a medical emergency. Treat them and do not again repeat the penicillin ever. Whereas Jarisch-Herxheimer reaction, it's not a anaphylaxis, so penicillin should not be withheld, it should be continued if it is required. And to reduce the inflammation, we can give the steroid. Okay. So to summarize, we have this Treponema pallidum which is going to produce acquired syphilis or congenital syphilis. Acquired, we have primary, secondary, late and tertiary syphilis, right? And dark field microscopy and VDRL, RPR, these are the investigations you know. TPHA is a serological treponemal test, and you remember the treatment is with penicillin, and the patients can have anaphylaxis or there could be Jarisch-Herxheimer reaction. So this is all about the syphilis. I hope you have understood. If you have any doubts, you can ask in the comment section, and also there is a playlist for all the university exam questions. You can check the link for the playlist in the description below. Thank you so much. If you like this video, please do that like button and do subscribe this channel for more such awesome videos on a regular basis. Thank you so much. Happy learning. Bye bye.